Yes, Asita, you may start now.
Thanks. Good evening, all. I welcome all of you to the first ever GP's Cafe meeting for 2024. I'm the Spice Route Chair for Sri Lanka for the year 2024, and I'm very proud to present this GP's Cafe today with Dr. Haroon Thawfeek and my CPD coordinator, Dr. Uh, Praneeth Nishad from Horana. Dr. Praneeth Nishad is going to be today's moderator. So he's a GP for more than 10 years, and he has done his diploma in child health and MCGP in 2020. And Dr. Praneeth will introduce Dr. Haroon Thawfeek, today's GP's case presenter. Dr. Praneeth, the screen is yours. Praneeth, you're muted.
Dr. Haroon Thawfeek, he's a part-time GP. He qualified MD and MCGP in 2023, and he has been practicing for about 6 years in his prior practice in Vida Clinic, Barnes Place, Colombo 3, and RN Health Clinic, Colombo 7. And he is also serving for government service as a medical officer, Department of Radiology, Sri Jayawardenepura General Hospital. Today, topic will be decoding chest X-rays, a journey through intriguing cases. We'll be having a fruitful discussion on chest X-ray application at GP's perspective. Especially saying this is a GP session, so we'll be more focusing on as a GP how to tackle chest X-rays as a GP. So we'll join with Haroon's presentation. Dear Dr. Haroon, please start your presentation.
We can't hear you, Haroon, properly. Can you please check the volume and if you have reduced the computer sounds, please.
Can you hear me now?
Yes, very well. Yes.
Perfect. So first of all, I would like to thank Dr. Hasita, Dr. Praneeth, and also Dr. Sankar for giving me this opportunity. And also I would like to thank the Spikes Root Young Physician Forum and also the College of General Practitioners of Sri Lanka for giving me this opportunity. So without further ado, let's jump into our cases. Before I, show the cases, I want to tell you a quote told by one of our senior radiologists that he was on the verge of his retirement. He said when he saw the last cases of chest X-ray, he said, "Now I am little bit experienced in looking at chest X-rays." So basically, what that means is chest X-rays, even though they are chest X-rays, they sound basic, but you have to have a good knack for it, and you should have plenty of practices to catch certain things. And also, now since this is a discussion-based case series, I don't want only myself to be talking. You can jump in between and ask any question at any time. Okay. And now you would have seen that I have chosen white as the background. So it's because of the effect the illuminator gives you when you have the X-rays on the illuminator. So that's how it is. And you can see my illuminator also at an arm's length away. So that's how the background looks. So just let's jump into the first case. Make sure that you take the video section away from the X-rays so that you can see the X-rays fully. And also if you're using a device, a small device, a phone, you can actually pinch in to zoom. So you can do that and make sure that you take a look at the entire X-ray series. Now, I will read you the case number 1. An 18-year-old male presents to your clinic with shortness of breath, following an episode of sudden onset left-sided pleuritic chest pain. A slim, tall, healthy young man. So this is the giveaway point, and all the symptoms he has is sudden in onset. And also his clinical examination is unremarkable, but he is still mildly dyspneic. You request a chest X-ray for further assessment. So can anybody tell me what's wrong with this X-ray? Is there any problems you see in this X-ray? You can take your chance. No worries. We are not going to judge if you make mistake. So
Size of the heart is smaller.
what did you say?
Size of the heart is smaller.
So you're telling me the size of the heart is smaller.
Yes.
Okay. Yes.
Absent bronchoscopy shadows in the left lower zone.
Yes. Okay. So the thing is now, it is very hard for you to be there and point the problems at me at this X-ray, right? So what you can tell me, you can divide the lung zones into 3 zones: the upper zone, middle zone, and the lower zone. Right lower zone, left lower zone. You can talk to me in that way. Okay. And also you can comment about the heart, the ribs, and all those stuff. So in this X-ray, as one of the doctors pointed out, there is an absent area of bronchovascular marking. Okay. So that area is this very specific place. Now in this place, you can see all the vascular markings goes to the periphery. You can see the pulmonary vasculature. You can see the bronchioles all reaching to the periphery, except in this place. So in this place, you don't have any form of vascular marking. So obviously, this patient is having a spontaneous pneumothorax. Okay. So spontaneous pneumothorax is very uncommon. Okay. But there is a small niche in patients, especially male patients who are very tall, right? They are healthy. They don't have any known diseases. All of a sudden, that is the giveaway point. All of a sudden, they have sudden onset of symptoms such as sudden onset dyspnea, maybe pleuritic kind of chest pain. Okay. So in those type of situation, you might think of that patient having a spontaneous pneumothorax. Okay. And also now getting X-rays nowadays, getting X-rays in a PP setup in Sri Lanka is not like, getting blood investigations. So blood investigations sometimes are overdone, rightfully so. I'm not telling that's wrong. For example, a patient comes with a viral infection, viral fever, you might suspect dengue, then you order full blood count, ESR, CRP, all those stuff. No problem. That's actually good. But when it comes to X-rays, we are always a little bit backwards. So X-rays are really underappreciated, and also they are less prescribed. Okay. So, and the other thing now, some of you might say, I'm at the, peripheries. It's really hard for me to get X-rays done. I can understand your situation. But at the end of the day, I'm talking about an ideal scenario. Okay. So in ideal scenario, these situations, which I'm going to explain, X-rays would be beneficial. Okay. So in this area, you can see the lung fields are absent. So this is a spontaneous pneumothorax. So now, since this patient is symptomatic, you have to admit this patient. And since this is a small pneumothorax, aspiration or drainage is not attempted, this will resolve spontaneously. And this patient, since they're symptomatic, they have to be admitted. Okay, all right. So did you people get this? Was I clear on this?
Clinical
Yes, sir.
examination unremarkable is less likely, no? This spontaneous pneumothorax.
Spontaneous pneumothorax is very, very rare. But the giveaway point, which is asked frequently in MCQs also, if the patient is a male, very tall, slanky patient, very tall patient, if the symptoms are sudden onset, all of a sudden the patient is playing some cricket or basketball, all of a sudden, or even seated, they get a sudden, shortness of breath, okay, there is pleuritic chest pain, then you have to think about spontaneous pneumothorax, okay?
Dr. Haroon, someone has suggested Marfan syndrome. Is it the case you are now talking about, the tall man?
Yes, so Marfan syndrome is a separate case. So Marfan syndrome has problems with their connective issue, and they are also prone to get spontaneous pneumothorax. No doubt about that. But there is a specific niche among patients who don't fall into the Marfan criteria, but still tall, especially male, for some reason. Still, scientifically, nobody knows why they get spontaneous pneumothorax. Okay, but Marfan syndrome people also prone to get it frequently. Is that clear?
Yes, thank you.
All right. Okay. So let's go to the next case. So a 40-year-old woman has presented to your clinic with increased breathlessness and left-sided pleuritic chest pain. Remember, so she is coming with breathlessness and left-sided pleuritic chest pain to your clinic. She has no significant past medical history, but takes oral contraceptive pill. Okay. She returned from a holiday in Australia, and obviously you don't go by boats to Australia, you go through flights. So she was seated in the flight for a long time. On clinical examination, reveals a raised respiratory rate, and a chest X-ray was requested to look for any lung pathology. So do you see any problems in this X-ray? If you're using a device, you can actually pinch out to zoom in and see. I'd be really happy if somebody can comment on this X-ray. So what is the problem we are thinking here? What might this woman have?
Pulmonary embolus.
Exactly. Okay, that is what we are thinking. Okay, so this patient could have pulmonary embolism. And the chances are really high. But the question is, can you see pulmonary embolism, especially if it is in the early stage, especially if it is a minor pulmonary embolism situation, can you see it on a chest X-ray?
No.
It's really hard. There are situations where you can see wedge-shaped infarctions, triangular wedge-shaped infarction, but it's really rare. So, and it got to be a very large thromboembolism. Okay, so this is a very normal chest X-ray. One of the hardest thing in radiology when it comes to chest X-ray is to call a chest X-ray normal. It's really hard. So you got to be really experienced to do that. So I want to bring this case in because during the COVID crisis going on in Sri Lanka, there were a lot of DVT cases and also pulmonary embolism cases. At the time, we saw a sharp rise in physician ordering chest X-rays just to exclude pulmonary embolism. Okay, so even though they were right, many people had pulmonary embolism with DVT, but chest X-ray is not a proper modality, initial modality for excluding pulmonary embolism. So the initial, we have to go through a criteria called the well scope So Wells score is the determinator whether the patient might have developed pulmonary embolism or not. Okay. And if you really suspect pulmonary embolism and there is obvious DVT in the leg, then you can straight away go to do what we call a CTPA, computer tomorized pulmonary angiogram. So that would be a better investigation rather than wasting time in chest X-rays. Okay. So is there any questions on this? No. And also I want to, tell you, please be careful. Please always make sure that you look into these two specific regions in the X-rays. So these are called the claustrophrenic angles. Really important, because if the claustrophrenic angles are blunted, that it shows that the patient might have some form of a pleural effusion going on. Okay, and also look at the tracheal position, whether it's in the center, deviated or not, and all those stuff. And also look at the pulmonary markings on both the sides. Okay, so let's go to our next case. So the next case is very interesting, right? Even though it's rare, it happens. Okay, so let me read it out to you. So a 60-year-old woman presents to your clinic with severe abdominal pain, right? She recently injured a back and has been using a lot of analgesia. On examination, she's unwell with a peritonic abdomen. PR examination is unremarkable. You request an erect chest X-ray to look for what? Perforation. So why we suspect perforation here? It's because the abdomen is peritonic, it tends, right? It's severely tender, and the patient had a very bad usage of analgesia. Okay, so you suspect peptic ulcer, probably, which is perforated. Okay, so can anybody or somebody or everybody tell, is there any signs of perforation in this chest X-ray?
Yeah, under diaphragm.
Perfect. Yes, there is air under the diaphragm. So this is the diaphragm, the right-sided hemidiaphragm. Under that, you can see a large bubble of air. Okay. So you can see a large volume of gas under the diaphragm. So this is a big telltale sign of a perforated viscous. So given the history of examination, it is most likely secondary to perforation, possibly of a peptic ulcer from the use of non-steroidal anti-inflammatory drugs. So at this time, obviously, you won't keep the patient in the clinic. You will obviously urgently refer this patient to a general surgeon, okay, or to emergency department or to the OPD. So in this patient, obviously, you can see air under the diaphragm on both the sides. So this is actually a very large, obviously very large perforated viscous. Perforation is quite large. Otherwise, you will see a tiny sliver of air under the diaphragm. So you see, in this case, in this patient, you see air under both the diaphragm. Okay. So let's go to our fourth case. And also, I want to tell you, if there is any doubt in between, feel free to ask the question at any time. You can stop me speaking and ask the question at any time. Okay. So the case number 4 is a 74-year-old man presents with a gradually increasing breathlessness. Okay, so that point is really important. He's a lifelong smoker. Apart from a smoker's cough, which he has had for several months, he is otherwise well. On examination, he has oxygen saturation of 86, an increased respiratory rate, and reduced air entry onto the left. And you do percussion, and there is a dull percussion on the left side. So what can you see in this X-ray?
Large pleural effusion.
Yes, so that's quite large pleural effusion. Okay. So this is a very important case, important scenario. So this recently, this case actually happened to me. It was around a 70-year-old man walked in. He had a cough for 2 months. Okay. And he told me that he has lost 10 to 15 kg of weight. And he has previously been a heavy smoker, and he used to smoke even at that point, just 1 or 2 cigarettes. But previously, he was smoking at least 1 pack or 1.5 pack per day. So I'm not trying to point fingers here. So most of us, what we would do, okay, we would auscultate the patient. We would say that because of a busy schedule, we might not hear the dull percussion. We might not hear less breathing on that side. We might say that this is some form of a upper respiratory tract infection, which is going lower. So we might prescribe the patient some antibiotic and send the patient home. So in this scenario, we shouldn't, because this patient is a elderly patient who has an history of smoking. So definitely, I think it is a very good idea to do a chest X-ray in this case. So for my patient, it turned out to be cancer of the lungs, adenocarcinoma of the lungs. So this is also such a case. So now you might be wondering, why the pleural effusion? You don't see a mass here. So this pleural effusion is secondary to the malignancy. Okay. So here you can see a large homogeneous opacity consistent with a large left-sided pleural effusion, okay? And because of this large pleural effusion on this side, the cardiac shadow is also deviated, and also the trachea. You can see in this X-ray, the trachea is deviated to the left. Okay. The costophrenic angle on the right side is sharp. On the left side, it is gone. And also there is something called the meniscus sign, the concavity on top of the pleural effusion. Okay, so that also tells us that this is an effusion. All right, so let's go to our next case. A 57-year-old patient who has a previous diagnosis of laryngeal cancer comes to your clinic. So I just don't want to, talk about this case, because I put this picture here because important case is coming after a couple of minutes. So let's discuss about this X-ray on that case as well. I just want to ask you, what's wrong with this X-ray? Anybody?
NG tube.
The NG tube is not in position.
Exactly. So NG tube is not in the position. It has gone to the left bronchus. Usually the NG tube should come in a straight path like that and curve down into the stomach in this direction. So this is how the usual pathway of an NG tube should be. So this is in the wrong place. So obviously the NG tube has to be removed and replaced. Okay, and also you can see a number of old fractures due to a past road traffic accident. All right, so case number 6, a 65-year-old female comes to your clinic. She suffered SH, subarachnoid hemorrhage, 6 months ago. She has since had, then the aneurysm was coiled. Now you are reviewing her as she has become all of a sudden dyspneic and hypoxic. Okay. She has increased respiratory rate. Chest examination is largely unremarkable. You requested chest X-ray for further assessment. So can you tell me what's wrong with this X-ray?
Left-sided effusion.
Left-sided?
Right-sided.
Effusion.
So you said left-sided infection.
Pleural effusion.
Pleural effusion. Okay. So now, good, right? I really appreciate that you participated in this. It could be pleural effusion. But in this, you don't see the meniscus sign. If it is a pleural effusion, you will see the meniscus sign. It will be going like this. Okay. It's not like that. Here you see the opacification here. Okay.
Medius, you know?
Yes. Yeah. Now this is the problem. So you in this one you have a left lower lobe collapse. Okay. There is also a small left pleural effusion. So I put that SAH and all those things to bit confuse you and take you off the track, but that has nothing to do with this. So this patient is having a small collapse of the left lower lobe. Okay. So my question to you is, what is the most common reason for a lobe collapse? A lobar collapse or collapse of the lung. What is the most common reason? So this is a very frequently asked MCQ question in any type of examination as well. The most common reason is a mucus plugging. Anybody can have a collapse. You, me, anybody can have collapse. Because of if you are, having excessive chest phlegm, mucus, sometimes it can cause a plugging. Because of the pressure difference, it can, collapse the specific lobe or a zone in the lung. Okay. So this is what you see here. You see this diffuse opacity. You see a small blunting of the left costophrenic angle. That is what you see. Okay. All right. So let's go to our next case. Very interesting case. Okay. I want you to look at this X-ray and also hear me out on this. A 50-year-old female presents to your clinic with increasing breathlessness on exertion. So it is increasing breathlessness. It's progressive. And there's chest pain. Examination reveals slightly muffled heart sounds. So if you're a good GP, you will use your stethoscope properly. Okay. So now you hear slightly muffled heart sounds. Okay. And when you look at the neck, comparatively to other veins, the jugular vein is bulging. Okay. So what do you think?
Pericarditis.
Cardiac effusion.
Pericardial effusion. Exactly. Yes. So this is a case of pericardial effusion. Okay. Why pericardial effusion? Why can't we say this is just an enlarged heart? It's because of the counter. It's well demarcated. If you see how beautiful it is demarcated. The pericardial pouch, because it is filled with fluid, you have this globular shaped heart. This is what you call the globular shaped heart. It's well demarcated. Okay. So yes, it is a pericardial effusion. Okay. So obviously you can't treat pericardial effusion in your GP setup. Definitely you have to refer this patient. So what are the causes? What are the frequent causes of pericardial effusion? So even a massive heart attack can cause a pericardial effusion. Renal failure can cause it. Hypothyroidism can cause pericardial effusion. So keep that in mind. Okay. And if you want to technically explain why the heart is enlarged, there is something called the cardiothoracic ratio. So the heart's cardiothoracic, the heart's transfer measurement is more than 50% of the cardiac thoracic ratio. So in that case, we say that the heart is enlarged. Okay. Okay. So this is case number 8. A 76-year-old female came to your clinic with her caretakers to change the NG tube. Okay, this is a frequent scenario. No? The nurses in your clinic have inserted the NG tube. So in most of the places, the nurses do the job when it comes to the NG tube. Okay. It was easy to pass the NG tube, but it was not possible to aspirate anything from it. Okay. The nurses have informed you and you requested chest X-ray to check its position. Very smart doctor. So this is a good time to order a chest X-ray, especially if the facilities are available close by. So what do you see in this X-ray? Anybody?
The NG tube has coiled up.
Yes, exactly. So the NG tube has coiled up, and there's one important thing also you have to notice. What is it?
The right sided On the right side below the diaphragm.
What do you see?
Yeah, the diaphragm is right side.
Yes, exactly. You see dilated bowel loops. Okay. So some people, because of adhesions and because of past surgeries, they can have chronic bowel obstruction. There is something, the bowel obstruction can be either acute or chronic. Some people can have, undiagnosed chronic bowel obstruction for a long, long time. So this particular, not this particular case, this thing has happened in my practice as well, where a patient has had tense abdomen with a lot of dyspeptic symptoms and also infrequent vomiting. Okay, she has been to multiple places, not properly diagnosed, and because of the tense abdomen and the way the abdomen was looking, I actually got a X-ray done of the abdomen. So I saw dilated bowel loops, and the referral was done, and it turned out to be a chronic bowel obstruction, and the patient was successfully operated. Okay. Now, my question to you is, why wouldn't you, doing an ultrasound on this patient is not that efficient way to diagnose this? Why is that? Why shouldn't we do an ultrasound on this patient? It's better to directly go to a CT than to an ultrasound. Why is that? Anybody? Okay. So the
AI
reason
is
is
not sensitive. In ultrasound
ex
scan, AI is not sensitive.
exactly. Exactly. So you can't use the word sensitive. The thing is, ultrasound uses sound waves, okay, to go in and bounce back. Okay. So it goes through, tough medium. Okay. It needs fluid, it needs, solid materials to go through. If there is air in between an ultrasound force, it can't penetrate. So that is the problem. So you will see a large amount of gas in the ultrasound. You can't see anything. You will basically see bubbles and bubbles of air. So there is no penetration. So doing an ultrasound at this, some might even consider, but it is really a bad idea. Okay. So this is what you can see. You can see dilated bowel loops. You can see the nasogastric tube is in the wrong place. And obviously, so this NG tube has to be reinserted. Okay. And also you have to do a surgical referral for this patient to find out why exactly a bowel loops are dilated. So let's go to case number 9. A 35-year-old man presents with breathlessness and a productive cough. Okay. On examination, he has a raised temperature and increased inspiratory rate. There are crackles at the left base. You requested, obviously, in this situation, better to go for a chest X-ray as early as possible. So what do you think of this X-ray?
It's lower zone consolidation. Suggested pneumonia.
Perfect. Yes. So that is the right perfect answer. That's lower zone consolidation. So this is a community acquired pneumonia. So you can see consolidation here. The right costophrenic angle is clear. The left costophrenic angle is blunted. So there is a new criteria nowadays to, treat pneumonia patient. It's called curb 65. Does anybody have an idea on that?
Consciousness and urea and respiratory rate and blood pressure in age 65.
Exactly. So C, it's a mnemonic. So C stands for confusion, U stands for urea. You can also take serum creatine. R for respiratory rate, B for blood pressure, and 65 is the age. So it goes as 5 points. If out of 5 points, if the patient has 2 points, you can actually treat the patient in an ambulatory way. You can actually treat your patient in your GP setup. right? So this incident has actually happened to me. So a couple of years back, I actually all of a sudden got a a right-sided chest pain. I was feeling feverish cold. Okay, especially at night, I used to feel a little bit jittery, and day by day this started increasing. So as usually all the GPs, which is bad, I tried to treat myself. I got an X-ray. Then after that, I saw a small consolidation in the left basal aspect. So, but afterwards, I made the right decision. I went to a chest physician. The chest physician obviously went through this. He said, you don't have none of these criteria. All these are good. So I think he gave me augmentin and clarithromycin. Within a couple of days, I was feeling better and I completed the course. Okay. So that is how it is. So it is not necessary for you to panic if the patient is having consolidation that you have to admit the patient and refer the patient. So according to this criteria, you can actually treat the patient in a GP setup. Okay. Right. So this is case number 10. A 7-year-old girl is brought into your practice by her father. She has developed a cough and a fever. On examination, she has some crackles in the right mid and lower zones. You request a chest X-ray. So from this itself, it's a giveaway. She has some crackles in the right mid zone and lower zone. So can you see anything wrong in this X-ray? Anybody?
Yeah, bronchogram in the right side.
Yes, yes. So you can see some opacification in the right mid zone and the lower zone. So there is also a form of consolidation because you can see air bronchograms. So I don't think that you can see this in your devices. You can see less opacified air bronchi so running through this entire opacification. So those are signs of consolidation. So this patient, since this is a young patient, okay, the curve 65 criteria doesn't match to this young patient. So definitely you have to send the patient for expert opinion and also think of admitting this patient. Okay. So case number 11, a 39-year-old asthmatic male presents to your clinic for the 3rd time this month. Okay. He has come with worsening of symptoms, worsening shortness of breath. Now, this 3rd time, the patient is hypoxic, tachycardic, with reduced air entry onto the right. You requested chest X-ray. So what do you see? If
Right
anybody
side
can tell.
X-ray?
Air trapping, right side air trapping.
Good, good, good.
Right side of bulle?
I think you can see a bulle type thing because of the first and the second rib over here. So that is not a bulle, okay? But I appreciate your trying. But you can see that there is a sliver of opacification in this right upper zone. Okay. So this is a right upper lobe collapse. So this is a very common thing, right? We people, usually don't think of this, but in an asthmatic patient, all of a sudden, there is a massive worsening of symptoms. You have to definitely think of this. Okay, in that particular time, no problem. You can, refer this patient for an X-ray. So what do you think the cause in this case? Why would a patient with asthma get a collapsed upper lobe? It is because, as I told you previously, it is because of mucus plugging. So it is one of the most common reason. Okay, it is not necessary that you have to have a malignancy or TB or all those stuff. The most common reason is mucus plugging. And now you might ask me, why don't we think of, now then since there's an opacification, why it is not pneumonia, any of those such things. Okay, it's because there are some signs of collapse. Okay, here you can see the right-sided hilar region is actually pulled to the top. Okay, and also here you can see that the trachea is deviated to the right. It's really important. So because of that, here the trachea is displayed to the right, and the right heart border is also pulled to the top. So this shows that there is a collapse. Okay. So this is not air under the diaphragm, hemidiaphragm. This is actually prominent gastric bubble. So make sure that you don't confuse that. Majority of the X-rays can have gastric bubbles. Okay. So you have to differentiate between air under the diaphragm and this. All right. So let's go to our next case. So if you have any questions, you can, get to me at any time. Okay. So this 80-year-old patient is brought to your clinic with confusion and fever. That's really important. Confusion and fever. Examination is difficult, but you think that there are some right-sided crackles. Then you get the green signal to do a X-ray. Okay, you've done the X-ray. What do you see in this X-ray?
Lobar pneumonia.
Perfect. Yes, that is the answer. You can see consolidation in bronchograms. Okay, it's a lobar pneumonia. Right upper lobe consolidation, keeping with community-acquired pneumonia. Then, according to the curve 65, would you treat this patient ambulatory in your GP practice, or would you prefer this patient? So the patient is obviously, see, confusion is there. Okay. Respiratory is obviously high, as I told you. The patient is 80 years old, so almost 3 points there. Okay, then definitely you have to admit the patient. Okay. Right. Let's go to our 13 cases. 13th case. A 73-year-old woman with background of COPD presents to your clinic with a productive cough, increasing shortness of breath and fever. Clinical examination reveals reduced air entry and some crackles in the right lung. Chest X-ray is performed. What do you see?
Bronchiectasis.
What do you say? Bronchiectasis. Yes, there is a bit of bilateral ozone bronchiectasis going on. Very good, very good. The most important thing is reduced air entry in the right lung.
Fibrotic heart pulmonary.
Yeah, so this patient is having right lower lobe consolidation here. Okay. With background changes of COPD, as someone pointed out, there is a bit of bronchiectasis also going on. So another important thing is, even when you treat your patient according to the curve 65 criteria, so how do you know the infection is getting better? You go according to the clinical scenario, or you get the X-ray done again? What do you think? We have to do a repeat X-ray, usually within 1 month. See whether there is any, resolvement. Okay, because if the lesion is still there, then obviously it could be, malignancy, it could be TB and all those stuff. So a follow-up X-ray is definitely needed. Okay. Now the thing is, the consolidation in this case is actually, most of it is behind the heart. Now, how do we classify that? Differentiate that. Now, the opacification, the density in the heart should be almost equal on both the sides. Here you see the density of the right and left side of the cardiac rhythm. Right side is more dense than the left. Then we suspect of a consolidation just posterior to the heart. Okay. So we are approaching the end. So there are 15 cases in this. So this is the 14th case. Let me read this out to you. A 73-year-old man has presented to your clinic with severe abdominal pain. He has past history of hypertension, diabetes, osteoarthritis. He is taking a variety of medication, including metformin, lisinopril, and ibuprofen. Okay, so this is important. He's taking some form of an NSAID. And he's coming with abdominal pain. On examination, he is tachycardic with peritonism. His abdomen is tense. Okay, it is severely tender, especially in the upper abdomen. So now we have the green signal to do our screening test for, I won't say that word, I will ask you. You request a chest X-ray. So we discussed a scenario in the last 13 cases, which is also almost equal to this. Can anybody see a problem in this?
Right side air under the diaphragm.
Yes, very good. You have nicely seen the X-ray, so you can see a tiny, thin layer of air under the diaphragm. This is really important. Okay, now you would have seen I have not taken any complex cases. These are typical GP scenarios. Okay, so in that case, which I showed you, there was a lot of air. So I put this case just to show you that it is not always that prominent. Okay, so you have to properly look under the diaphragm, and here you can, if you can zoom in, you can see this tiny line, dark line under the diaphragm. Okay, so this patient definitely, so there is some bilateral apical pleural thickening as well. So that is not related to our case. So this is what you have to look for. Then definitely an urgent surgical referral has to be done on this patient. See, subtle free subdiaphragmatic gas. Okay, so let's go to our last case. A 4-year-old boy is brought in by his mother with a cough and a fever. On examination, he is pyrexic with an increased respiratory rate. Chest examination is difficult. He's 4 years old, he's crying. Okay, but you think there might be a left-sided crackle. You somehow auscultate the patient and there is a left-sided crackle. You request a chest X-ray. Okay, the thing is, the threshold for chest X-rays for young children should be really high. You can't unnecessarily expose children to radiation. Okay, but in this case, if we have solid evidence, okay, and also we auscultated and found this evidence, then we can move on to perform chest X-ray. So what do you see in this chest X-ray? Anybody? Here.
Left-sided lower pneumonia.
Exactly. Exactly. So this chest X-ray shows consolidation within the lingula. Okay, here's the lingula. Basically, you can call it lower zone. It's not necessary that you have to go into this deep. Obviously, the child is having pneumonia. Okay, and this child, obviously, you have to send the patient for urgent care. Patient definitely has to be admitted. You can't go according to the curve 65 criteria. So we have came to the end of our presentation. I see some questions in the chat box, and many people have answered correctly. Many people have answered on the chat box. So thank you so much. Thank you so much for engaging in this presentation. Thank you for your attention. Does anybody have any question which I can clear? Anybody, any question? So guys, if you want this presentation, I will be happy to give it to you. And also, if you have any questions regarding anything, you can also reach out to the Spice Route. You can reach out to the College of General Practitioners and get to me. And this is also my WhatsApp number. If anybody needs this presentation, they can put a text to me. I will be more than happy to forward this to you. Thank you so much.
Thank you, Dr. Haroon Thawfeek, for your good presentation on X-rays with related to some A&E, but more relevant to GP practice, because some of the cases we find as GPs. So we think that even it is more in A&E, but they will present to our places as well. So I would like to thank you with a certificate prepared by our college that is sent to your WhatsApp now. So it is shown in the presentation area now. It is signed by our chair as well as the college chair. So as well as we invite the members as well as the doctors who join the session to join our GP Cafe's WhatsApp group. It is pasted on the WhatsApp chat box. Sorry, our Zoom chat box. You can copy those things in your thing and join.
Dr. Praneeth, before everybody leaves, I have a quick message. If you people are interested in more X-rays, you can, ask the college and you can ask the Spice Route because I will be more than happy to bring more X-ray cases and radiological cases. I'm actually thinking of doing another series on abdominal X-rays. So if people are interested, please, you can request it.
Yeah, feedback came from our seniors is to review it beforehand we present it. So we'll review it. We'll have some more abdominal X-rays with relevant to your GP practice. So thank you very much, Haroon. Please, the members who join the session, copy the GP Cafe's WhatsApp group link and join in future for the future reference. So we'll be ending the session up to now. Thank you.
Thank you so much, Dr. Praneeth. Thank you so much for the opportunity. Thank you so much.
Okay,
Thank you, Dr. Haroon and Dr. Praneeth, for nice, very interesting evening session. And we will be presenting monthly wise GP's Cafe. So if you have any idea of presenting with us, please talk to us in GP Cafe. We can give you a chance. It should be more relevant to the GP's perspective. So all the GPs will be very much delighted to have that presentation. Thank you for joining us. We had 85 participants for the first session. That's a very interesting and a very encouraging participation. Thank you all and good night. We'll meet you again.
Good night.
Thank you.
Good night all.